We have a 28-year-old female who says, my tongue looks different than I'm used to. She has type 1 diabetes and lupus. She wears a partial denture on the mandible, and the lesion can be wiped off the tongue with gauze. And we're asked, what is the most appropriate treatment? Now, before we determine the most appropriate treatment, let's determine what diagnosis the patient currently has. And the important clue that we're given here is the fact that this lesion can be wiped off the tongue. This should really be the only clue that you actually need to diagnose it. But your picture can really help too. A lesion that can be wiped off almost always points towards a candidiasis infection. Now, candidiasis is a yeast that can present as an oral fungal infection. Whether it develops and its severity depends on the host immune status, the oral mucosal environment, and the virulence of the candidiasis strain. It's important to note that this is a very common, if not the most common, oral opportunistic fungal infection. The patient has lupus, which means that she's likely taking a corticosteroid to treat her condition. Corticosteroids suppress the immune system and would make the patient even more susceptible to this opportunistic infection. Now, oral candidiasis can present in different forms, such as pseudomembranous and erythematous. The first and more common form is pseudomembranous candidiasis, which is also known as thrush. In this form of candidiasis, we see these white, curdled milk or cottage cheese-like plaques that can be wiped off. That's the big clue here. So in this patient, we're seeing this tongue, and we've just wiped off these white plaques. This is common on the buccal mucosa, the palate, or the tongue, and it may be asymptomatic, but a burning or unpleasant taste is occasionally noted. This is the lesion that's being wiped off the patient's tongue, just like we said. The erythematous lesion we're seeing in this picture is what's underneath the wipeable plaque, and it indicates the presence of erythematous candidiasis as well. Erythematous candidiasis is characterized by an area of redness with variable borders. The tongue is a common site, but it can affect the oral commissures or even the palate or perioral skin. Candidiasis is also seen pretty commonly in patients who wear dentures, just like our patient. Now, a culture or exfoliative cytology can be done to determine if this is definitely candidiasis, but the fact that it's able to be wiped off is a pretty conclusive indication. Now, because this is a fungal infection, let's get back around to the question of the most appropriate treatment. Now, because this is a fungal infection, this would be treated by administration of an antifungal medication. Superficial oral mucosal infections can usually be treated with a mild or systemic antifungal agent. So this would include clotrimazole oral troches, dissolved 5 times a day for 10 days, nystatin oral suspension for soaking dentures, and fluconazole taken systemically. Life-threatening infections usually require intravenous amphotericin B, so that's how they're treated, these different antifungal medications. Now let's go through the other answer choices and talk about why they're incorrect to treat candidiasis. We'll start with a biopsy. Now, the most important thing to say about a biopsy is that this is usually done to diagnose a condition, not really to treat it. A biopsy is also usually not even necessary to diagnose candidiasis because we can diagnose it from the clinical presentation of that wiping off. We can diagnose it through exfoliative cytology or via a culture. A biopsy would do nothing to treat a candidiasis infection, and we usually don't even need it to diagnose a candidiasis infection. So this is definitely wrong. And next we have administration of an antiviral medication. Now this answer choice would be incorrect because candidiasis is a fungal infection and not a viral infection, so antivirals would really do nothing. Antiviral medications could be used to treat other things like herpes or the flu, but they would do nothing for a candidiasis, a fungal infection. And lastly, we have administration of a corticosteroid. Now, this answer choice would be incorrect because candidiasis is a fungal infection and not an immune-mediated condition. So corticosteroids, kind of like we talked about earlier, suppress the immune system and are taken for immune-mediated conditions like lupus or pemphigus vulgaris. And like I also said earlier, taking a corticosteroid would actually exacerbate a candidiasis infection because the immune system would be weakened and the opportunistic fungus could flourish. So this would actually be the complete opposite of what you want to do when you have a candidiasis infection. So you definitely don't ever want to prescribe any kind of steroid if a patient has an opportunistic fungal infection like candidiasis. So when we have this patient who her lesion can be wiped off the tongue with gauze, it definitely points to candidiasis, and this image can help. And when we have candidiasis, an opportunistic fungal infection, we definitely want to treat it with an antifungal medication. This question is asking which condition is most likely to be associated with oligodontia, cleidocranial dysplasia, trisomy 21, Ehlers-Danlos syndrome, or ectodermal dysplasia. To be able to answer this question, you not only have to know what oligodontia means, but you have to know a bit about each of these conditions. So since it's specifically talking about oligodontia, we'll start by defining that. Oligodontia is a dental abnormality characterized by the congenital absence of 6 or more permanent teeth, not considering the third molars. And if you just break down the word, oligo or oligo means few or little, and dontia just means teeth. Now, it falls under the term hypodontia, which is just the developmental absence of some teeth, but it's a more specific term that indicates at least 6 teeth are missing. This anomaly is typically caused by genetic mutations or abnormalities that disrupt the formation of teeth early on in the developmental process. And although it can occur independently, it's usually seen as part of a syndrome or genetic condition. Now, oligodontia can also affect the primary teeth, and the most common permanent teeth to be affected are the maxillary laterals, second premolars, and the first molars, but this pattern can definitely vary from patient to patient. And out of these answer choices, the condition that is most likely to be associated with oligodontia is D, ectodermal dysplasia. And this makes a lot of sense if you think about the condition and what it is characterized by. Now, this developmental condition is a group of inherited disorders in which 2 or more ectodermally derived structures do not develop normally or fail to develop. This condition has several patterns of inheritance depending on the type and is characterized by hypoplasia or aplasia of the skin, hair, nails, teeth, and sweat glands. Clinical features include fine, blonde, or light-colored hair, periocular hyperpigmentation, heat intolerance due to lack of sweat glands, protuberant lips, prominent forehead, varying degrees of xerostomia, brittle nails, hypodontia or oligodontia, abnormally shaped crowns, tordontism, and teeth with conical roots. And you can kind of see the oligodontia in this picture. This picture is a patient with ectodermal dysplasia. Now, treatment for this condition includes genetic counseling for patients and parents and will likely include fixed, removable, implants, and orthodontics depending on the individual case. So because ectodermal dysplasia is definitely associated with oligodontia, seeing as teeth are ectodermally derived structures, we knew that this answer choice was incorrect. Now let's still go through the other answer choices and talk about these conditions a little bit. And we'll start with cleidocranial dysplasia. Now this is an uncommon autosomal dominant inherited bone disorder, but it can also be due to spontaneous mutations. This condition affects the skull, jaws, and clavicles primarily, and it leads to bones forming differently or more fragile than typical bones. It's called cleidocranial dysplasia because cleido actually refers to the collarbones, and cranial refers to the skull, while dysplasia refers to abnormal growth. This condition results in the non-closing or delayed closure of the fontanelles, which are the soft spots you've probably heard of between the skull plates in infants. Characteristic features include a prominent forehead and a hypoplastic midface. Other features seen in patients affected with this disorder include a long neck, shoulders that are narrow and drooping due to those hypoplastic or missing clavicles, hypermobility of the shoulders, and a short stature. Dental findings seen in these patients often include a high-arched palate or cleft palate, a retained primary dentition due to the permanent teeth not erupting, as well as numerous impacted and supernumerary teeth, and you can see that in this image. These patients are not missing teeth, but they often don't erupt in the correct space or fail to erupt in general. Treatment for this condition is combined surgical and orthodontic care to correct skeletal relations, remove supernumerary teeth, and correct the alignment of the permanent teeth. The prognosis is good, and the lifespan for these patients is essentially normal. So because patients with this condition have supernumerary or extra teeth, cleidocranial dysplasia is definitely not associated with oligodontia, which is a decrease in the number of teeth. So because one of the mutated genes in this condition leads to excess teeth and not a reduction in the number of teeth, we knew that this answer choice was incorrect. Next, we have trisomy 21, which is more commonly known as Down syndrome. And in babies with this condition, they have inherited an additional chromosome at position 21 instead of just the pair that is typically seen. This syndrome is seen in 1 out of every 691 births, and the risk for this syndrome increases as the age of the mother increases as well. Symptoms of this condition include a flattened face, almond-shaped eyes that slant upwards, a protruded tongue, a short neck, mild to moderate intellectual disabilities, musculoskeletal and movement problems, congenital heart disease, and shorter than average height. Dental problems associated with the condition include delayed eruption of both dentitions, hypodontia and microdontia, tordontism, macroglossia, malocclusion due to a small maxilla, and an increased risk for periodontal disease. Treatment for this condition involves a multidisciplinary team and is based on each individual's physical and intellectual needs. Now, although this condition is typically associated with hypodontia, or the loss of a few teeth, it does not usually present with oligodontia, which is a more severe presentation requiring at least 6 teeth to be missing. And because of this, we knew that this answer choice was incorrect. Next, we have Ehlers-Danlos syndrome. This syndrome is a group of connective tissue disorders that are caused by mutations in genes that code for collagen and other components of the extracellular matrix. These disorders primarily affect the skin, joints, and blood vessel walls, and are characterized by tissues being more elastic or fragile than normal. The most prominent features or symptoms of this condition are hyperelasticity and fragility of the skin, hypermobility of the joints, a tendency to bruise or bleed easily, chronic pain, and possibly cardiovascular issues. Possible complications include joint dislocations, rupture of blood vessels, skin wounds and scarring, and early osteoarthritis. Dental manifestations include increased risk of periodontal disease, poor wound healing, bleeding gums, TMJ problems, delayed tooth eruption, and malocclusion. The treatment for this condition depends on the specific subtype that the patient has, and it includes physical therapy, pain management, skin care, surgeries, and cardiovascular monitoring. There's currently no cure available for the condition. Now, although this condition can cause the appearance of missing teeth, as teeth are lost due to periodontal disease or poor tissue health, Ehlers-Danlos syndrome is not associated with the congenital absence of any teeth, making this answer choice incorrect. So because the condition that is most likely associated with oligodontia, and really the only condition that is associated with oligodontia at all, is ectodermal dysplasia, we knew that this was the correct answer choice. Cleidocranial dysplasia, trisomy 21, and Ehlers-Danlos syndrome are not associated with this dental abnormality. We have a 60-year-old female who says, my lip is swollen. She has type 2 diabetes and has a pacemaker, and we notice a swollen lip, facial weakness, and a fissured tongue, and we're asked what the most appropriate treatment is. Now, since this question is asking us the most appropriate treatment, we need to determine the patient's diagnosis to be able to make that call of the most appropriate treatment. And now let's go ahead and look at some clues. Now, honestly, all three of the current findings are essential clues to making this diagnosis. These three together, this swollen lip, this facial weakness, and fissured tongue, are the three hallmark symptoms of a specific syndrome known as Melkersson-Rosenthal syndrome. all three need to be present together to have this syndrome, which is why it's very important that we were given all three as current findings for this question. Now, Melkerson-Rosenthal syndrome is a rare neurological disorder characterized by those three findings. That's really what it is. You see this non-tender lip swelling known as orofacial granulomatosis. You see facial weakness known as Bell's palsy and a fissured tongue. Now, the onset for this condition is childhood or early adolescence, so this patient has likely had these symptoms to some degree for many years. Now, let's talk a little more in depth about each of these characteristics of this syndrome. The first is what the patient is complaining about, the swollen lips. This orofacial granulomatosis is a type of non-necrotizing granulomatosis inflammation that presents as a non-tender swelling, and it can vary in size over time. The second characteristic is facial weakness that's also known as Bell's palsy. Now, Bell's palsy is the most common non-traumatic cause of facial paralysis and is associated with cranial nerve 7, which is the cranial nerve responsible for innervating the muscles of facial expression. So that's what allows you to smile, open your eyes, all kinds of stuff. Now, this muscle weakness causes half the face to droop and results in trouble making facial expressions, as well as trouble keeping the mouth and eye closed, which is why you can have your eye starts to tear up, you could drool. Those are characteristics of Bell's palsy. Now, the final characteristic of this syndrome is a fissured tongue, which is actually just a variation of normal and is seen in 5% of the population on its own, not just with this syndrome. This fissuring varies in severity, with the midline fissure being the most common, but it can range up to an extensive tree-like pattern present on the tongue. Now, treatment for this condition includes a lot of things, but always starts with ensuring the patient has a thorough medical evaluation and that all sources of inflammation have been removed. NSAIDs and immunosuppressants can be given for treatment, but intralesional corticosteroids work best for the swollen lips, so answer choice C would be correct here. Multiple injections may be necessary to reduce the orofacial granulomatosis, but there is generally a good prognosis, as this is actually mostly just a cosmetic problem. As far as the facial weakness and fissured tongue, the facial weakness will typically resolve on its own without treatment, and the fissured tongue really doesn't require treatment, as it's just a variation of normal. Now let's go through the other answer choices and discuss why they would be incorrect for this question. We'll start with antiviral medication. Because this syndrome is a neurological disorder, it is not associated with the virus and therefore would not be benefited from an antiviral medication. Although Bell's palsy on its own is oftentimes associated with the viral infection, it still would not benefit from antivirals, and Melkerson-Rosenthal syndrome as a whole would definitely not be treated via this modality. Antiviral medications would instead be used to treat viral infections such as herpes or the flu. Next is an antifungal medication. Once again, this syndrome is a neurological disorder. It's not due to a fungus, and antifungal medications would do nothing to treat this condition. Antifungal medications would instead be used to treat fungal infections such as candidiasis and aspergillosis. And finally, chemotherapy. Now, this is a treatment modality that is used for I'm sure you've heard of it. It's used for cancerous lesions, and because this syndrome has no association with the malignancy, it would not be treated this way. Chemotherapy works by stopping or slowing the growth of cancer cells, and there's no excessive growth of cells causing the symptoms in this syndrome. Chemotherapy would instead be used to treat other oropharyngeal malignant conditions and cancerous conditions throughout the body. So when we're seeing this triad, these hallmark syndromes, these swollen lips, this facial weakness, this fissured tongue, we know that this patient has Melkerson-Rosenthal syndrome. It's a very specific syndrome, and that would be treated with corticosteroid medications.
This question asks, each of the following are differential diagnoses of the radiographic finding except one. So let's look at our answer choices. First, we have a periapical cyst and periapical granuloma. These are both found at the apex of a non-vital tooth as a well-rounded unilocular periapical radiolucency, and that is exactly what we're seeing in this radiograph, so we can eliminate these answers. Next, we have an apical scar. This would be excessive connective tissue formation after endo treatment. Since this tooth was endo treated, we can expect that this may be an apical scar and include it in our differential. Finally, we have a KOT, or a keratocystic odontogenic tumor. This would be found in the posterior mandible as a unilocular or multilocular radiolucency with corticated and scalloped borders. This is not what we're seeing in this picture, as this is not in the posterior mandible, nor is it a multilocular radiolucency, and just isn't the consistent presentation of a KOT, making option A the correct answer to this question. This question asks which abnormalities indicated in the image, and it's most important to note in the patient box that this patient had their 4 first premolars previously extracted. So looking at the panoramic radiograph, we can see these radiopaque structures, and we want to see what they are. So these would not be normal findings, nor would they be an odontoma of any kind, because these would be radiopaque masses of tooth structure, and this is not what an odontoma would look like. Instead, these are supernumerary premolars, and it's very important to note in the patient box that they had their premolars extracted so that we don't think that this is a normal finding. So option D, supernumerary premolars, is the correct answer to this question.
So this question is a pretty straightforward definition, so we need to be able to recognize what lesion is being described. We have a benign neoplasm of odontogenic origin, appearing radiographically as a radiopaque mass, fused to roots and surrounded by a thin radiolucent rim in the mandibular molar region, and it's most likely to be what? Now, this is an entire definition, so the whole thing is really important to us, but let's focus in on some important details that can really help us make the distinction among the answer choices. First is the fact that this is fused to tooth roots. Now, this is a huge clue for our lesion and is basically a giveaway because this really only applies to one lesion that we were seeing here. So we definitely want to keep that fact in mind. Also, the fact that this is found in the mandibular molar region. Now, a lot of things are found in this lesion, in this area, but knowing what it is and knowing where it's found can help us distinguish it from other lesions that appear similarly. So we are definitely seeing a cementoblastoma based on this description. And I've attached a really great photo over here to kind of look at when we talk about this description. Now, just like the question says, a cementoblastoma is a benign tumor of odontogenic ectomesenchyme, and that radiographic description, that fusion to the tooth roots, is pathognomonic for this lesion. And that basically, pathognomonic basically just means that a sign or symptom or description is unique to a lesion. So when we see this fusion to the tooth roots and we see this radiolucent rim, this is always going to be a cementoblastoma. Now, in this case, you can see that radiopacity fused to the tooth roots, and we see that narrow radiolucent rim around it, and that is contiguous with the PDL space of that tooth. Now, if you were to surgically extract this tooth, the cementoblastoma would come with it. So it's almost like the tooth has like a shoe or a boot right on the end. Now, these teeth are always vital, so that's an important detail to know because in a lot of lesions, they're not vital. And this is mostly found in the mandibular molar region, like we said, and it's usually on that first molar, so that's more information to keep in mind. Now, this is usually slow growing, and in 2/3 of the case, it presents with pain and swelling, which is actually not very common for a lot of lesions found in the mouth. We also usually see this in patients under 25, which is pretty young, and there's no gender predilection that's associated with it. So that's all great information to know. Let's go ahead and go through the other answer choices and talk about what they are and how they're similar and different from a cementoblastoma. So we'll start with an ameloblastoma. Now, this is a tumor of odontogenic epithelium, and it's actually the most common odontogenic tumor. It's known for being locally aggressive, and the expansion of it can be dramatic, so it's definitely something to know about it. Now, how is this similar to a cementoblastoma? It's also a benign odontogenic tumor, like we said. It's also slow growing, and it's also most common in that similar region, that molar ramus region of the mandible. But ameloblastoma has more variety in where it appears compared to the cementoblastoma. Now, how is it different? Now, this is usually painless. It doesn't have that pain and swelling that's usually associated with the cementoblastoma, and it can be associated with impacted teeth as well. The average age for this is 33, which is a little bit older, and it has this unilocular or multilocular lesion with well-defined borders. It's known for being expansile and having this soap bubble presentation, as you can see in the picture on the left. It kind of looks like a bubble bath, so that's what it's known for being described as, and that is kind of a buzzword for this condition, so keep soap bubble in mind. Let's go ahead and talk about the periapical osseous dysplasia. Now, out of all of them, this is the lesion that appears the most similar. If you look at the picture to the left, it looks pretty similar to that cementoblastoma. So I'm definitely going to tell you how we can kind of keep it separate in our mind and make this distinction every single time. So periapical osseous dysplasia is also known as periapical cemento-osseous dysplasia. So osseous dysplasia and cemento-osseous dysplasia are the same thing. Now, cemento-osseous dysplasia as a whole is the most common fibro-osseous lesion encountered in dentistry, and it's a benign disturbance in bone that may originate from the fibroblasts of the PDL, or it could just be a defect in bone remodeling. We're not entirely sure right now. So cemento-osseous dysplasia is kind of a spectrum, and periapical cemento-osseous dysplasia is the mild form of that spectrum. Now, how is this similar and how is this different from cementoblastoma? So it's similar in the fact that we see it in vital teeth, and it's very radiographically similar, like we said. So we have this, normally it starts with this radiolucent circle, and then as the lesion progresses over time, we get more radiopacity growing in the center. So the more radiopaque you see in the center, the longer the lesion's been there. And that's how it's very similar to our cementoblastoma. Now, how can we differentiate these two? Now, the radiographic difference here is that the PDL is intact for a periapical osseous dysplasia, and it was not intact for cementoblastoma. So cementoblastoma, we saw that radiolucent rim kind of being contiguous with the PDL space, and here that's not true. You can see it is clearly separated from that radiopacity in this lesion. So that's an important distinction to be able to make. Now, this is also often located in the periapical mandibular incisor region. So we usually see this anteriorly as opposed to posteriorly in the mandibular molar region for the cementoblastoma. So that's another important detail. This is also usually painless and there's no swelling, as opposed to 2/3 of the time with the cementoblastoma where there was pain and there was swelling. Another important trend to know is that this is usually seen in middle-aged Black females. So we're seeing slightly older patients, and we have a strong gender predilection for this lesion when compared to the cementoblastoma. Now let's go ahead and talk about the Staphny bone cyst, also known as a Staphny bone defect. Now, this is also just really a lingual mandibular salivary gland depression. So this is kind of just a developmental defect. It's not really a pathognomonic condition. It's just a defect. Like, some people's mandibles are just like this. Now you can see it over in this image, and we'll kind of talk about what it is. So similar to cementoblastoma, it's seen in the posterior mandible. It can be in the anterior, but it's usually in the posterior, so it's a similar area as the cementoblastoma, but this lesion will always, always, always be below the mandibular canal. That's an important thing to know. It's always below that canal, and that's just the location that's always going to be found on based on the defect that it is. So that's how you would kind of distinguish it from the cementoblastoma. It's not associated with tooth roots or anything like that. This is also usually asymptomatic and is usually seen in adult males. So that's another distinction that we can make. So when we're seeing this description and we see this lesion with this radiolucent rim fused to tooth roots on a mandibular molar, we always want to keep in mind that it is likely not even likely, that it's always, always, always a cementoblastoma. This question is asking, each of the following is a common symptom associated with obstructive sleep apnea except one. Which one is the exception? Nocturnal choking, evening headaches, daytime sleepiness, or dry mouth on awakening? Now, this is a great question, as obstructive sleep apnea is something you will definitely see in patients, and they will often even come to you with questions about it. There's even a big movement with people practicing sleep dentistry, and they're actually seeing and treating a lot of these patients. So also, if that's something that interests you, you should definitely make sure you know the answer to this question. Now, before we talk about the symptoms of obstructive sleep apnea, or OSA, talk about it as a whole. Now, if we break down the name, sleep apnea refers to a disorder that occurs when your breathing starts and stops while you're asleep, and obstructive just refers to a blockage. So in this condition, this breathing problem is due to some kind of obstruction or blockage. There are a number of risk factors associated with this condition: enlarged tonsils or tongue, obesity, as the excess weight can contribute to that airway obstruction, being male, being over 40, and a number of medical conditions such as hypertension and type 2 diabetes. Social habits such as smoking and excessive alcohol use are also risks. You've likely had to do some kind of OSA screening in some of your dental patients, so you may be familiar with some of those risk factors. Now, to officially diagnose this condition, a sleep study is often done to measure breathing patterns and oxygen levels while a patient sleeps. Treatment for this condition varies based on its severity, but it often includes lifestyle changes like weight loss and avoiding alcohol, as well as a CPAP machine and even surgery if it's severe enough. But back to our question here, what are common symptoms of OSA? Now, the most characteristic symptoms are loud snoring, choking or gasping during sleep, excessive sleepiness during the day due to lack of deep sleep, difficulty concentrating, morning headaches, irritability, nighttime sweating, and waking up with a dry mouth or sore throat. And because these are the symptoms seen in these patients, we know that B, evening headaches, is the incorrect answer. Now, this was a little bit tricky because patients with obstructive sleep apnea do often experience headaches, but they experience morning headaches and not evening headaches. Now, these headaches are the result of oxygen deprivation during sleep, cerebral vasodilation, and just a lack of sleep in general. These patients experience a number of symptoms at night while they're trying to sleep, but evening headaches is not one of them. So although we know that the other answer choices are common symptoms associated with obstructive sleep apnea, let's still briefly go over them and explain why they occur. We'll start with nocturnal choking. Now, this is definitely a symptom seen in obstructive sleep apnea and is honestly one of the defining features of the condition. This occurs due to those repeated episodes of airway obstruction. This can be due to obstructive structures like an enlarged tongue, or due to the muscles of the throat relaxing, collapsing, and blocking the airway. Now, once the brain notices the lack of oxygen the person is receiving because their airway is obstructed, there is a reflexive response that causes the person to wake up and they'll likely gasp or choke. But honestly, sometimes the patients are so tired that they don't even realize they're doing this, and family members will often be the ones to report that they're gasping or choking in their sleep. So some people don't even know that they're doing this. But because this is absolutely a common symptom associated with obstructive sleep apnea, we know that this answer choice was incorrect. Next, we have daytime sleepiness. Now, this is also definitely a common symptom seen in obstructive sleep apnea, and it makes sense if you think about it. If a person is unable to breathe while they sleep and they're constantly gasping and choking, then they really aren't getting a good night's sleep. So the combination of frequent arousals, the lack of deep sleep, and oxygen deprivation all contribute to the daytime sleepiness experienced by these patients. And once again, because this is absolutely a common symptom associated with OSA, we know that this answer choice was incorrect. And finally, we have dry mouth on awakening, and this is another example of common symptoms seen in this condition. Many people who suffer with obstructive sleep apnea will breathe through their mouths when they sleep because their nasal passages are actually usually the first to be obstructed. And if you've ever been sick in your life and congested and you had to breathe through your mouth to sleep, you know that you can definitely wake up with a dry mouth and a sore throat as a result. So patients with this condition also often sleep on their back, and that contributes even more to this dryness, and their constant gasping contributes even more. So they're breathing through their mouth a lot, they're laying on their back, and they're gasping all the time. They're definitely going to have a dry mouth when they wake up. And because this is definitely a common symptom associated with obstructive sleep apnea, we knew that this answer choice was also incorrect. So when talking about obstructive sleep apnea, we know that common symptoms include nocturnal choking, daytime sleepiness, and dry mouth on awakening, but do not include evening headaches. In this condition, we see morning headaches, but they're not experienced in the evening. This question is asking which is most affected by the human immunodeficiency virus, red blood cells, CD4 T cells, CD8 T cells, or platelets. Now this is a great, straightforward question and one that could be easy points on the boards if you know this information. So let's make sure that you do. The human immunodeficiency virus is a virus that targets the immune system. You can kind of tell by the name. This infection can be found in most bodily fluids and is usually spread via sexual contact or injection drug use. Signs and symptoms of HIV depend on the stage of infection. Initial symptoms are flu-like and they include fever, headache, and sore throat, while later symptoms include swollen lymph nodes, weight loss, and diarrhea. And as this condition progresses even more, profound immunosuppression in patients with the condition can result in opportunistic infections, neoplasms, and other systemic effects. Head and neck manifestations are also very common in HIV and may even be the first sign of an HIV infection. There is unfortunately no cure for this infection, but antiretroviral drugs are used to stop the virus from replicating in the body and can prolong the lifespan of someone with this condition by many years. If untreated, HIV will progress to AIDS, or acquired immunodeficiency syndrome, and this occurs when a certain cell count drops to a certain level. But what cell does this cell count refer to? Going back to the question, we want to know what is most affected by the human immunodeficiency virus. HIV targets the body's white blood cells, serving to weaken the immune system, and the specific cell that is affected is B, the CD4 T cell. CD4 T cells are also known as helper T cells, and they serve to coordinate the immune response by stimulating other immune cells. HIV attacks these cells, preventing the body from fighting off infections, and it does this by getting inside these CD4 T cells and replicating. And this process will kill those cells and allow the new HIV copies to be released and to target additional CD4 cells. So it kind of gets in there, replicates, and the process speeds up and cycles even more. A normal CD4 cell count for a healthy adult is 500 to 1200 cells per cubic millimeter. A low CD4 count is below 500 cells, and that would indicate HIV. And if the level gets below 200, then it's classified as AIDS at that point. Now, because this is the cell affected by HIV, we know this answer choice is correct. Due to the fact that this virus does not target other cells for replication and destruction, we know that the other answer choices are incorrect. But let's still briefly discuss each one and talk about what conditions can affect them. We'll start with red blood cells. Now, these are cells found in the bone marrow and blood that are responsible for transporting oxygen to your tissues and carbon dioxide to your lungs via hemoglobin. These cells are also known as erythrocytes, and there are a number of conditions that can affect these particular cells, including anemia or polycythemia. Anemia is either due to having not enough of these cells or having defective ones, resulting in less oxygen being transported through the cells, while polycythemia is an increased number of these cells leading to thickened blood and increasing the risk for a heart attack or stroke. But because red blood cells are not affected by HIV, this answer choice would be incorrect. Next, we have CD8 T cells. Now, this was probably the trickiest answer, as it can be difficult to remember the difference between CD4 and CD8 T cells. CD4 cells were the helper cells. They help out by triggering the immune response after recognizing certain pathogens and secreting signals to activate other immune cells. CD8 T cells are known as cytotoxic T cells, and they are the cells that actually destroy infected cells. To help with remembering the two, I remember in my brain that the immune system has to be triggered before cells would be destroyed, just like CD4 has to come before CD8 numerically. So you trigger before you destroy, and 4 comes before 8. So that's how I kind of keep them straight. Now, CD8 T cells are affected in many chronic immune conditions, such as rheumatoid arthritis, Crohn's disease, lupus, Sjogren's syndrome, multiple sclerosis, Graves' disease, and many more, but they are not affected in HIV, making this answer choice incorrect. And finally, we have platelets. Now, they're not cells, they're actually cell fragments rather than full cells, and they're also known as thrombocytes. Platelets are made in the bone marrow and are responsible for forming clots to stop and prevent bleeding. Conditions that affect platelets include thrombocytosis and thrombocytopenia. Thrombocytosis is too many platelets and can lead to spontaneous clots, resulting in heart attacks or strokes. Thrombocytopenia is too few platelets, which can result in easy bruising and frequent bleeding. But because these cell fragments are not affected by HIV, this answer choice is also incorrect. So we know that when we're talking about the human immunodeficiency virus, the cells that are targeted would be the CD4 T cells, which are also known as the helper cells. And when this level of cells drop below 200, we've surpassed HIV and we're now dealing with AIDS. So this question is asking what tooth is most likely to have abnormal involution or infolding of enamel into dentin. Now, before we talk about what tooth this is most commonly found in, let's talk about what this is. Now, this involution or this infolding of enamel into dentin is known as dens invaginatus or dens indentae, and it's a dental abnormality where we see a tooth within a tooth. That's what dens indentae kind of means. And this is due to the invagination of the developing tooth bud. That's why it's called dens invaginatus. And what we are seeing is that the enamel is folding into the dentin of the tooth to form a sort of pouch or pocket. And this finding can be quite variable in severity and unfortunately can cause a lot of problems for the tooth. The invagination of the enamel usually needs to be sealed due to difficulty cleansing it because that invagination leads to a higher likelihood of contaminants or particles becoming lodged inside. Unfortunately, the affected tooth often becomes non-vital shortly after erupting, especially if the invagination has caused a pulpal communication, which basically means that the invagination goes straight through from the oral cavity, like the outside mouth, to the pulp. So there's that communication between the two. Treatment for this is, like I said, sealing it or a root canal. And that is a difficult root canal to do usually. Now, this is not a very common occurrence, but when it is seen, it is almost always seen in one particular tooth, and that is what this question is asking. And that tooth is the maxillary lateral incisor. So when we have dens invaginatus or this abnormal involution or infolding of enamel into dentin, you always want to think the maxillary lateral incisor. Now, I wish I could say why we see it most commonly in this tooth, but we don't really know. We don't really know what causes this in the first place or what causes this to happen in specific teeth. So I couldn't really tell you why it's most commonly found here, but it is definitely a fact that you need to remember because it could definitely come up in a question. So we'll just go through it. It's not most common in the maxillary central incisor. It's not most common in the maxillary canine. It's not most common in the mandibular canine. So when we see dens invaginatus, this abnormal involution or infolding, we always want to know that it's most common in the maxillary lateral incisor. And I don't know if this will help you remember, but your maxillary lateral incisor is kind of a weird tooth. It's associated with a lot of dental abnormalities, not all of them, obviously, but it's associated with this dens invaginatus, like we just talked about. It can also be a peg-shaped. It's known for being like microdontia, like the small peg-shaped lateral. It's also the most common maxillary tooth to be congenitally missing, other than your wisdom teeth, of course. Your wisdom teeth would come first, but then your maxillary lateral, it's often not seen. And like I said, that's kind of a lot of dental abnormalities. So I'm not saying that it is a trend for every dental abnormality. It's not something to always assume, but maybe it'll help you remember the dental invaginatus that we're seeing here is most associated with the maxillary lateral incisor, just because it is kind of an odd tooth and we see a lot of abnormalities with it.